Okay, Assalamualaikum and a very good morning to everyone in the auditorium. My name is Izzah. I'm a pharmacist in Hospital Putrajaya. So my topic today will be on TDM of anti-seizure medications or anti-epileptics as we call it. Okay. So this is the overview of my slides. The first one is about pharmacokinetics. So a brief overview about general PK. TDM for anti-seizure medications, and lastly we'll have one case discussion. Okay, so moving on, just a quick callback or flashback to our university years. So pharmacokinetics is the principles of ADME, starting with absorption, which will apply to all the drugs in the world basically. So how will it get in? And after that, distribution, where will the drug go? Metabolism, how is the drug broken down, and finally excretion in how does it leave the body. So, and we know this as well, this is an example of what happens to the drug levels in the body after an oral administration of the drug. So, as you can see, there is this absorption phase that occurs. And there will be a time lag before the Tmax at which the Cmax happens. So the Tmax and the Cmax, basically Cmax is the maximum concentration of the level in the blood. Tmax is the time at which that Cmax happens. Okay, this is especially important in oral administration of anti-seizure medications. We will discuss more on this later. Okay, so we also have the what we call therapeutic window or the therapeutic range, as many of the drugs have, which is the minimum effective concentration and the minimum toxic concentration. So ideally, we will want the drug level to be somewhere in this nice blue window. Okay, so many of the drugs that we actually do TDM, the therapeutic window is very narrow, what we call narrow therapeutic index drugs lah. Okay, so at below the minimum effective concentration, we expect the drug to have no effect. And above that, there is where the drug toxicity happens. Okay, what we don't see here is actually the Cmin, the minimum concentration of the drug in the body. Of course, if you give one oral dose of any medication, the Cmin will finally be 0. But in serial dosing of medications, we expect the Cmin to actually be somewhere around here, because this is ideally where you would give the next dose. So you don't want the level of the drug to actually go below the Cmin level. Okay. Okay, so this is an example or a graph that shows the time taken for the drug when after you give a maintenance dose of it, when will it reach a steady state. Okay, so for many drugs, it will reach about 4 to 5 half-life before it will reach the average steady state concentration. So this is also important because we don't want to be taking the levels too early. Because they will not reflect the final concentration that we expect in the patient's system. Okay, this is regarding pharmacokinetic and also pharmacodynamic interactions. So pharmacokinetic basically is explaining what the body does to the drug. So all your ADME just now, and pharmacodynamic interaction actually shows what the drug does to the body. Of course, if there is any altered absorption, altered distribution, altered hepatic metabolism, or altered renal excretion, we will expect some level of drug changes in the body. Those that we can quantify with TDM. This is where we get to see the levels change. But there are also pharmacodynamic interactions that we actually cannot see any changes in the plasma concentration, because these are pharmacodynamic interactions. This is where pharmacist input will be very valuable. Okay, you can do TDM, but your pharmacist will try to figure out what's going on. Why is this not? Why is patient not getting the effect that we expect from the patient? Okay. So, moving on to TDM for anti-seizure medications, the drugs that we have available for TDM is only phenytoin, valproic acid, carbamazepine, and phenobarbital. So this is in government hospitals in Malaysia. There are some private settings, I know that they are running levetiracetam or lamotrigine, but we don't really have it available in many hospital settings lah. Okay. Okay, so mechanism of action of the drugs. If you can see here, I'm not going to go in detail about this. If you can see, there are a lot of overlaps between the MOA of the drugs. Okay, so phenytoin and carbamazepine share the voltage gated sodium channel, MOA, benzodiazepine and barbiturates are GABA receptor agonist. Okay, and also you have the valproate over here. Okay. So as you can see, because of the overlap of the MOA, there are also potential drug-related problems that we can expect. The first one, of course, being inappropriate dose. There are also a lot of suspected toxicity, side effects, non-adherence in many of the patients. I would say for actually all the diseases or all the patients taking the medications, up to 70% of patients are not taking their medications as prescribed or as given. Okay, so drug-drug interaction, drug-disease interactions are also things that you need to consider, and also adverse drug reaction. Okay, so talking about all that, what are actually the indications for TDM in anti-seizure medications? Okay, in many of the, if you talk about antimicrobial drugs, those drug levels that you take, I feel more straightforward. Okay, for TDM in anti-seizure medications, there are a lot patient-related considerations that you need to think of. Okay, the first one is, of course, clinical toxicity. You don't really have to think much about it. So if patient comes in with toxic effects of the medications, of course, you will do a TDM. Okay, and then secondly, you can also do compliance assessment in patients with uncontrolled or breakthrough seizures. Thirdly, you can help to guide dosage adjustments in pharmacokinetically variable population. So generally, any PITS patient, elderly patient, or patient with associated diseases such as renal or liver impairments. And then fourth one is actually to guide dose adjustment for phenytoin, specifically phenytoin, more than the other drugs, because it is a zero-order elimination drug. So it's not so easy to estimate what would be the level for the patient would be based on calculations alone. So you need to take a level for that. And then lastly is when a pharmacokinetic change is anticipated. So pregnancy, if there is any addition or removal of interacting drugs, and also if there is any generic versions and something like that, you have to think about if there is any changes in the levels. This is where we do the indications. It is not for all patients. Okay, if you see a lot of the recent guidelines, they actually say that TDM are most often over requested, and also this will lead to injudicious alteration of drug doses. So yeah. Okay, this is a sampling guide for the 4 drugs. So you have the drug, you have the reference range, which is different for every drug, of course. If you can see here, like I mentioned, a lot of the drugs are narrow therapeutic drug, narrow therapeutic index drugs. So with phenytoin, you only have 10 to 20 levels, basically, that you can play around with. And it can easily overshoot and undershoot very easily. And then the time to steady state, like I mentioned just now, about 4 to 5 half-life before you reach the steady state, which means that this is the time before you can start monitoring your patient. Okay, you cannot start on Monday and take a level on Tuesday. It would not be a steady state, and we would basically a wrong sampling time can cause wrong suggestions lah. Okay, wrong dose recommendations. So valproate acid, you need to wait about 2 to 4 days after any drug dose changes or after initiation before you can change the, you can do a TDM. Carbamazepine is a bit special because there is an initiation phase. So anytime you initiate carbamazepine, you need to wait about 2 to 3 weeks. This is because of the PK auto-induction part of carbamazepine. Okay, and then after any dose changes, you can do it after 2 to 5 days. And phenobarbital, you need to wait about 2 to 3 weeks. So these are because of the long half-life, it will also take a longer steady state before the level can be achieved. Okay, and then the sampling time for all the oral medications, these are for oral anti-seizure medications. The pre-level should be taken about 30 minutes or just before dose. So this is also very important because, like I said just now, when you have an oral administration of the drug, there is time lag before it reaches Cmax. So that can take about 2 to 4 hours or even more, depending on the drug, before we reach a level that we can. Basically, what I'm trying to say is we cannot know at which point the absorption, is it done, is it not done, is this a level true, is this level accurate. So the most accurate time for you to take a sample is actually pre-level. So you have to let the patient know that they have to pause in the morning before you take a level. Okay. Okay, so these are the pharmacokinetics of ASM. So you can see the bioavailability here. Generally, they are very well absorbed. The Tmax will take about 4 to 8 hours or up to 12 hours for phenytoin. The protein binding is especially high in phenytoin and valproate. This is the half-life and VD of the drug. So this is what we use, the population parameters, to help estimate what are the levels that patients should get in their body. Okay, drug-drug interactions. Actually, you cannot escape drug-drug interactions when we talk about these old generations of anti-seizure medications. So, the first group, carbamazepine, phenobarbital, and also phenytoin are all enzyme inducers, means that they induce the hepatic enzymes in the body and induces the metabolism of other drugs. So what they do is actually they reduce the levels of many of other drugs, okay? And then you have valproic acid, which is an enzyme inhibitor. So an enzyme inhibitor means that it inhibits the hepatic enzyme in the liver, and also what it does is actually increases the level of other drugs. Okay, so, okay, moving on. This is the drug-drug interactions for all the carbamazepine, phenytoin, phenobarb, and valproate. So, it will also, it will interact with each other. So, carbamazepine can interact with phenytoin, with phenobarb, and valproic acid. Actually, they all interact with each other, but also they are interacting with other drugs. Such as antidepressants or antimicrobials. So we have to go and check one by one what drug patient is taking before deciding a dose change or anything like that. Okay, so this also is the list of drugs that is interacting with enzyme-inducing anti-epileptic drugs. So carbamazepine, phenytoin, phenobarb. I'm not going to go through the list one by one. Okay. So when we talk about adverse drug reaction, we have to consider what it means. Okay, so you have the therapeutic effect, which is the intended effect of the drug. So anti-seizure medications, you expect the seizure control to improve generally. So side effect, not necessarily harmful. So you can use a lot of the drug side effects for the other purposes as well. Okay, so adverse effect may be harmful. Okay, prolonged adverse effect may affect organ function. So this can induce in your hepatic injury and something like that. You can also do dose reduction or switching of the AED to minimize harmful consequences. But toxic effect, usually it happens when the drug is taken in excess. So an overdose of the drug. It can be life-threatening and drug must be stopped. Okay, so we move on to ADR for each of the drug. For phenytoin, there is dose-related side effect and non-dose related. So basically what it says by dose is higher dose means higher concentration in the body. So concentration-related side effects, you have more than 20, because the therapeutic range or the reference range is 10 to 20. More than 20, you expect some sort of nystagmus going on. More than 30, ataxia, and more than 40, diminished mental capacity. So there are a lot of other side effects of phenytoin, like gingival hyperplasia, hirsutism, peripheral neuropathy, but these are not dose-related side effects, and it's actually not an indication for TDM in patients receiving phenytoin. Okay, and then there are also lots of other non-concentration-related side effects. So drowsiness, headache, dizziness, rash, pruritus, and also cutaneous drug reactions like DRESS, STS, and TEN. Okay. The next one is valproate. So the concentration-related side effects is a bit less, is a bit more general compared to phenytoin. So you have, when the serum concentration is 75, more than 75, patients who can complain of tiredness, lethargy, sedation, and ataxia. When it's higher, more than 100, is tremor. More than 110 or more than 135, it will be probability of thrombocytopenia. And also when you have extremely high serum concentration, that is when CNS toxicity can happen. Okay, so a lot of other side effects. These are non-concentration related side effects. Okay, so a bit more general. If you're unsure, you can always send a level lah. Okay. This is the ADR for carbamazepine. I would just like to highlight the most common one is actually dizziness, drowsiness. Okay, here, dizziness and drowsiness. Okay, and then you also have the life-threatening event which can happen if patient has the genetic component for carbamazepine metabolism. So that one is actually rash, which can induce cutaneous drug reactions. So your SCS, your TEN. Okay. And then you have ADR for phenobarbital. So this is more I would say because sedation and respiratory depression is very, very important to think of in phenobarbital. But actually, not many patients are on phenobarbital nowadays. So yeah. Okay, moving on to case discussion. Okay, we have a patient, LMP, a 65-year-old female. She was admitted for breakthrough seizure secondary to post-stroke epilepsy. She was currently or previously on tap sodium valproate 400 mg/d. So upon ED admission, she complains of no fever, septic parameters not significant, no electrolyte abnormalities. They did a CT brain and found an old cerebral infarct, but no significant new findings. So patient claimed compliance to medication. She has no complaints of side effects. So the TDM valproate was taken. The level was found to be 48. And our reference range is actually 50 to 100. So these are all her lab investigations. And they did a TDM for her. The patient was started on valproate like last year. So last dose taken the day before admission at 8 p.m. And the sample was taken in the morning. So the patient came in around morning time the next day. Okay, so there's no issue with the steady state. More than 2 to 5 days for valproate. And then it's taken as a pre-dose level. And then patient claim compliance, no missed dose. So if you see the level as 48, what would you think? Is patient compliant or not? How do you know based on the level? Okay, so as pharmacists, this is what we do. A lot of calculations, the formulas, and keying in all this. And I'm not going to show each of the calculation. I'm just showing what we do in the behind the scenes basically. Okay, so before any interpretation done, calculation must be made. And actually, if we want to know if patient is compliant or not, we have to consider the dose. What the dose will tell us, and the dose, some of other parameters as well, will tell us what is the expected level. So the patient is on 400 mg/d. By calculation, patient should get an expected level of between 38 to 65. So we don't look at the reference range first. We actually look here first. Okay. So the lab results found to be 48 just now. Expected level is between here and here. Do you think patient is compliant? Yes. Okay. Thank you, MC. Okay. So based on here, we can generally say that patient is most likely compliant Okay. And we did some digging as well and found out that previously on the same dose, they did a level for this patient at clinic as SOC setting. The level was 55. So 55, 48, we don't expect the level to be exactly to the dot, same every time. So 55, 44, I would expect it to be acceptable variation. Okay. So from there, we do a recommendation. So the TDM valproate acid level is slightly below the reference range. Okay, slightly below sahaja. Patient is most likely compliant to valproate. Okay, but patient came in with fitting and we don't know yet any other cause. So the next step for us logically would be to increase the dose. Okay, so how much can we increase? We go back to our reference, about 5 to 10 mg per kg per day at weekly intervals. So either we can increase the dose to 400 mg OM, 600 mg OM, so about 1 gram per day, or maybe even 600 BD, depend on the calculation. But based on 400 to 400 OM and 600 OM, the expected level is expected to be about 48 to 82. Okay, and then we can do a resampling of valproate level after 3 days, so after the steady state, and we monitor for the FPC, LFT, and other possible side effects. Okay. So the learning point from this case is we have to get correct sampling time and make sure that patient has actually achieved steady state before we do a sampling, because that actually helps to for us to do accurate interpretation. Okay, anything that is not before steady state or post level, we cannot actually interpret. What we will suggest most of the time is just to do another resampling at the expected correct time. Okay, and then compliance can be evaluated more accurately if patient has had a previous TDM result with the same dose of medication. So comparable levels with the same dose, very, very, very helpful. Okay, lab results when compared to reference range does not paint a full picture in regards to patient compliance. So we don't dia bukan macam FBC ke RP. We don't just tengok atas bawah macam tu. With anti-seizure medications, we need to do calculation. We need to know the patient's expected level. So reference range is not therapeutic range. When we talk about anti-seizure medications, we have to consider that patients can actually be responding even when the level is below reference range. Okay, like this patient just now, previously she was below reference range and was fine. Okay, and then we have to consider the individualized therapeutic range punya concept lah. Okay, expected level can be compared to population values to determine compliance. This is for pharmacists to help you calculate the expected level. Okay, same patient, she was admitted to the ward and the dose was increased to 400 mg/m and 600 mg/m. However, she developed another seizure episode in the ward. So they gave her a stat dose of IV diazepam, okay, and seizure was aborted. They also loaded patient with IV phenytoin 200 mg stat and continued with maintenance dose of cat phenytoin 300 mg/n. So patient was free after that and discharged after 3 days, given TCA SOC medical in 1 month. So the investigations were repeated after 1 month. So they did both TDM now, okay. So you added another drug in the picture. They did both TDM. So TDM valproate pre-level is 30. TDM phenytoin random level is 11. So if you can see here, previously when she came in last time, we actually increased the dose, but previous TDM was 48. Now it's 30. Okay, and phenytoin is something new here. So patient has been seizure-free since discharge and complains of mild headache sometimes. So what do we think? Is anything is patient even compliant to the valproate? We increased the dose, but actually the level decreased. What do we do? Okay, so, sorry. Okay, so this is the pharmacokinetic notes that you get something like this from the pharmacist. Expected level, again, if you want to determine compliance, we have to calculate the expected level. So valproate level is 30, expected level is between 31 to 38. And then the phenytoin level, 11 from the lab, and expected level from calculation is 13.6. These are the reference ranges. So if you can see here, clear cut, phenytoin dah masuk range lah. Okay, however you see it, memang okay. But valproate here, something wrong. Okay, so there's nothing in the sampling that is telling us this is a wrong sampling. So everything is fine. Okay, what happens is actually the drug-drug interaction lah. Okay, when you add on another new drug. So this is why your pharmacist might be like more inclined to suggest you to increase the dose rather than add on another new drug. Because when you add on another drug, especially if the drug is an enzyme inhibitor, enzyme inducer, it changes the story completely. Okay, so phenytoin is an enzyme inducer, but valproate is an enzyme inhibitor. We sort of expected the level of valproate to be lower when we introduce an enzyme inducer in the picture lah. Okay, so both are also strongly bound to albumin, but at certain concentration, valproate can also displace phenytoin from its binding site. So a lot more pharmacokinetic interactions going on here. It's a very complex interaction. Okay, so sometimes we can see it from the levels, but if you just ask me face value, no levels, I cannot tell you anything. And especially if you don't have any other previous TDM level, okay, need to take a level in this case lah. Okay, so the recommendation here is valproic acid is below reference range, but the phenytoin is within reference range. Patient is most likely compliant to both valproic acid and phenytoin. So this is based on just calculation. What do we do? Because patient is currently seizure-free, we don't actually suggest to do anything lah. Continue same dose. But we can monitor more, especially if patient develops another seizure, whether there is any drug changes that can be made, whether phenytoin is working better for this patient, whether valproate can be taken out. But usually I don't like to do all this thinking through just our documentation in paper. So a lot of this needs to be communicated verbally to the doctor. Okay, so for now, because based on what we see, patient is currently seizure-free. Continue the same dose. We can resample again in 6 to 12 months if patient remains seizure-free, and monitor for FBC, LFT and other possible side effects. Okay, so the learning points here, drug interaction can play a major role in changing drug levels and may affect seizure control. More drugs does not always mean better. So I feel like in the guidelines as well, monotherapy is always recommended. Okay, Of course, if monotherapy does not work, then you have to think about other things lah. Okay, frequent TDM is not necessary in patients with good seizure control. So we don't really need, if patient is no longer fitting for the past, I don't know, 2 years, 3 years, 1 year, we don't need to take a level every time patient comes to see the doctor, maybe every 6 months. So we don't need that. Maybe once a year would be enough just to get an individual range for that patient. We always have to ask, what do we plan to do with this level? Is there any changes that we would like to make, or we just want to see? Okay. Usually, what I don't know what to suggest actually when patient admits that he is non-compliant, but the prescriber sends a level anyway. So most of the time the level will be 0 or near to 0. So continue same dose lah. We cannot change the drug, we cannot add on the dose, we cannot do anything much at that point. So if patient dah mengaku tak comply, you don't need to send a level lah. Just advice for compliance. Okay. Patient history can tell us a lot, especially if there is any possible side effect or toxic effect that we can miss. Sometimes these side effects will not be seen in levels. Okay, patient can get a side effect even if the level is within range. Okay, we need to consider that as well. Okay, so other issues to consider: limited phenytoin dosing. So I would like to highlight phenytoin again here because we have 100 mg capsules of phenytoin, so just one strength. And we can basically just adjust to 100, 200, 300, 400. I don't think we go beyond 400. Maybe you can go up to 5, 6, 7, 8 based on literature, but I've not yet seen more than 400 mg per day of phenytoin. Okay, so we cannot, especially with phenytoin, if you want to do any dose adjustments, you have to take a TDM first because of the zero order metabolism. Okay. And then there's also consideration for HLB1502. This is an allele, genetic allele presence. Technically, if the patient has this allele, you cannot start on carbamazepine treatment. So this has not yet been officialized or documented, like the pathway on how to go about it if you want to start patient on carbamazepine. So we need to consider that before starting carbamazepine lah. Okay, so pregnancy or women of childbearing age or any interaction with OCP, we need to consider that as well. And if patients are on nasogastric tube feeding, so a lot of patients actually phenytoin capsules and tablet valproate cannot be crushed or cannot be opened. They have to be swallowed full. But I don't know, in primary setting, do you have syrup sodium valproate available? Do you have syrup phenytoin available? So those are the things that we need to consider, especially because of the level variations that you can get, especially when switching from drug to drug formulations. Okay. So the conclusion from me is TDM for anti-seizure medications can be a useful tool to help tie patient response with drug levels. But we need to do it carefully in consideration to correct sampling time, compliance, and also patient history. That's all. Thank you.
Thank you, Puan Izzah, for that valuable knowledge that she shares just now. And all that sounds so technical, right? But when in doubt, refer your pharmacist. So we maybe have time for 1 or 2 questions. Patient seizure-free for 2 years. Do we adjust ASM dose with just 1 episode of breakthrough seizure? Epi, is it epi? Expected dose range but slight low therapeutic dose.
Just 1 episode.
Seizure-free for 2 years, 1 episode of breakthrough seizure.
You mean if the patient has suddenly has one breakthrough seizure? Okay. What do you think, Izzah?
Okay. Of course, 1 episode of breakthrough seizure, I would find whether there are any, what do you call that? Triggers, yes. Is there any triggers? Has patient had any fevers, or is it like, you have to think a lot when it is breakthrough seizure. Because patient has been stable for 2 years, so there's a lot more investigation needs to be done. I would not just increase the dose. This is of course another discussion because I need a lot more information on this. Is patient ada meningitis symptoms ke, benda-benda macam tu. This one I would leave to the doctors usually, but kan, tapi banyaklah nak kena tanya. Okay, I would not just increase the dose lah. Kena consider the clinical case macam mana.